Okay, so the recorder's on, so we'll hit it. All right, well, welcome everyone. This is Steve Axe here from Chicago. Welcome to the next edition of National Journal Club. I am super excited. We have the Pittsburgh MedTalks group presenting today on, I know, a topic is all near and dear to our hearts, alcohol withdrawal, and we're going to hear about their experience. I'm very excited about this. So I'd like to welcome Tony Paisan. Anthony, I'm going to butcher your name, so I'll let Tony introduce you, and Ryan as well. But just the usual business that we have, if you're going to tweet, please be active on Twitter and use the ACMT NJC hashtag. And also, if you'd like to weigh in and say anything, please raise your hand, and we'd like to acknowledge you. Also, between articles, we'd like people to weigh in, and I know everyone's got an opinion about how to treat alcohol withdrawal. So with that, Tony, please take it away.
Thanks, Steve. So I have my two senior fellows here, Anthony Scochamaro, we can't pronounce his name either, and Ryan Marino, and so we'll just let them move forward.
Awesome.
All right, thanks, guys. Happy to be here. Yeah. Ryan shaking his head now. You guys can't see that. Okay, so yeah, we have a lot of personal experience with this, as I'm sure all of you guys do. We want to talk about adjunctive treatment, something we have to discuss oftentimes with our ICU and a lot of other consultants is what they should be doing for alcohol withdrawal aside from benzos. And we'll get to our own personal experience with ketamine at the end as well. So with that, I guess we'll move forward. So first and foremost, we want to provide this disclaimer that the first-line treatment is obviously our GABA-A agonist, so benzos, barbiturates. I'm sure that you guys are well accustomed to using those. So this is not replacement for that. These are only adjunctive measures. So why should you use adjuncts at all? So you might want to decrease your overall benzodiazepine requirement. If you have someone that has continued autonomic instability, it might make everyone feel more comfortable if you give them some of these adjuncts. And then lastly, we obviously have benzo-refractory withdrawal where benzos won't be as efficacious.
So yeah, we had a lot of GIFs in this presentation that didn't load correctly, but the first paper is about propofol. I'm sure you can draw your own conclusions about this image.
It was an outstanding moonwalk. I got to see it in all its glory.
So the propofol paper is a case series. They only had 4 patients. It was from 2000 in critical care medicine. These were all ICU patients who were intubated, and their first-line treatment in this series was a continuous lorazepam infusion, which is important because it was kind of interesting compared to what we do today. Yeah, they use a lot of lorazepam, I think, is the point of this GIF.
Can you do the voice?
Love it here, too.
So, yeah, we highlighted the requirements these patients had before they were started on propofol, and the cumulative doses of lorazepam in every patient was greater than 1,000 milligrams. And you can see the second patient actually got 3,650 milligrams, and this was over just like a couple of days. So going through the cases here, the first patient was a 36-year-old. Initially got these boluses, was a little refractory, started on the lorazepam infusion, and ended up intubated. He was on 80 milligrams an hour. And then was started on propofol at 90 mics and was maintained on this for 11 days without any sort of titration.
This is obviously what the patient said as they awoke from their propofol slumber. They had no idea what year it was, what day it was. Pretty long time beyond a propofol drip. We'll come back to that.
It's a lot of propofol to be honest.
A lot of propofol. This is a lot of Ativan.
Yeah.
You can go to the next slide. I was just highlighting that.
So the second patient who got the most Ativan was a 37-year-old, got intubated for coffee ground emesis actually initially, and then started to withdraw. And he got the 3,650 milligrams over 3 days, and then got switched to propofol, again at a pretty high dose at 80 mics. which he was on for 4 days, so not nearly as long, but still a long time on propofol. The third patient was similar, kind of like younger male, got a lot of Ativan, then was started on propofol at 45 mics for 4 days, which is kind of more reasonable sounding. And then the last one was the only woman in this series who was intubated for pneumonia, actually, and then withdrew from alcohol. She got 1,150 of Ativan, then was started on propofol at 40 mics, and she, again, was on it for 10 days.
And this is kind of showing the crossover. Most of these patients were on the lorazepam maximally at like the second day, and that's when they would start the propofol, and then usually they were off of the lorazepam completely by the third or fourth day. And then obviously, pretty variable in how long they were on the propofol, anywhere from, those 4 to 11 days ultimately.
So just discussing this paper, why does propofol work for alcohol withdrawal? It has dual mechanism GABA-A receptor agonism and NMDA receptor antagonism, which is similar to alcohol. It's reportedly faster to wean than midazolam was their justification in this paper for using it when used as sedation in the ICU, and that was based on previous data they had. And then the reason for using it as an adjunct would be in someone who's refractory to benzos, receiving super high doses of benzos, because the adjunct effect of the glutamate receptor antagonism. And then there is the propofol infusion syndrome, which I don't know if they were aware of in 2000, but the importance of following markers like lipids while someone's on propofol and trying not to keep them on for this long of a time period.
Yeah, so the limitations are pretty obvious in that this is a very small subset of patients, and they all have a lot of comorbidities for which they were actually admitted to the ICUs for. We don't really use lorazepam infusions as much anymore. Some places still do it, but obviously at these high doses you would worry about propylene glycol toxicity with that. Lorazepam has typically an 80% propylene glycol diluent there compared to diazepam, which is like 40%. And then this is only intubated ICU patients, so that obviously complicates it a little bit more. Some of them were intubated for reasons other than alcohol withdrawal or delirium tremens. And like we said already, they didn't really address if there was any concern for propofol infusion syndrome, but certainly most places wouldn't want to keep a patient on a drip for a total of 10 or 11 days. That kind of goes against their arguments of, oh, we think it's faster weaning times. Like 10 or 11 days is not really a short treatment for any type of DTs that we've been familiar with.
Yeah, and that graph of their doses of medications they were receiving shows they weaned the propofol pretty slowly. There was no attempt to kind of cut it. So that is interesting that that was what they said.
I'm sure you guys are familiar with David S. Pumpkins, as you know. Anyone else have any other questions or concerns with this paper?
Yeah, and again, please, anyone has any comments, raise your hand. And no David S. Pumpkin quotes today. I think this is a G-rated webinar here. Yeah, no, I think it really is an interesting paper. I think we've learned a lot also since this was published in terms of propofol infusion syndrome. Also the rate of intubation. I wasn't sure were all of these patients intubated. I wasn't sure about case 3. It looked like they all required mechanical ventilation.
Yeah, they didn't say it explicitly in case 3, but I think we're going to presume that they were intubated at that dose of propofol, but yeah, you're right.
Right, and I guess, and these were pretty prolonged treatment times in the ICU. All right. In terms of like the cocktail you guys use, where does propofol really rank?
For us, it's probably pretty close to the end of the line, where we're trying our benzos first, and then usually using barbiturate to bridge over to ketamine. We might add on Precedex too after we get to the ketamine point if they're not really well controlled, and then really if all else fails, then they're getting intubated. Sometimes, you know, we work closely with the ICU here, and sometimes they might jump the gun on our patients and opt to intubate them before we would like to, but we're okay with them being on propofol by the time that they are intubated and everything.
Sure.
I think the important thing is we just try to keep the alcohol withdrawal patient from ending up intubated if we can avoid it.
Yeah, I think we have a similar approach. And again, please, you know, other groups, raise your hand if you want to weigh in. We'd love to hear everyone's approach. Maybe after the next article, we'll ask some people to weigh in. Okay, well, how about if we keep moving?
Okay, next we're going to use Precedex as an adjunct. So this is a favorite of our ICU colleagues, unfortunately, or fortunately, however you want to look at that. So this was prospective randomized double-blind. They powered it with 24 patients. Ultimately, the non-intubated patients were monitored and diagnosed with CIWA. I'm not sure if all you guys are familiar with that scoring pattern. And then all the intubated patients were monitored with a Riker scale. So they randomized them into either placebo group or low dose or high dose Precedex, and everyone was getting benzodiazepines as a frontline treatment. And so they're thinking of using Precedex, dexmedetomidine. Sorry, I don't think people like me using the brand name. Dexmedetomidine. They wanted to try to spare the patients from getting excessive amounts of benzodiazepines. So not really sure if that is an outcome we can all agree on, but that's what they powered it for, the overall benzodiazepine dose over a 7-day period. They wanted to see if this would spare it. So this is the array of exclusion criteria. It is pretty extensive. If you want to just hit next, Tony. The one I wanted to highlight was administration of benzodiazepines for purposes other than alcohol withdrawal syndrome. So in that, they included seizures. And it's a little bit unclear, you know, if these patients had other underlying seizure disorders, or presumably if they were seizing in relation to their alcohol withdrawal. But all of those patients were excluded ultimately. And they had screened 200 and some odd consecutive patients to get to that ultimate enrollment of 24. So they did exclude quite a bit of patients from there. So this is, you know, all their baseline criteria. If we can just zoom in on the important ones here. I'll just hit next. It goes to the next one. Yeah, so you can see the differences here in baseline characteristics. The ones I thought were most interesting because of how different they were really the lorazepam requirement 24 hours prior to initiation. So you can see that low-dose dex group ultimately got 94 milligrams compared to 39 in the placebo group. So you would actually expect that these patients were either sicker or a delayed time to study initiation, and it turns out it's the latter there because their median time to initiation was about 34 hours compared to 10.4 in the placebo group. So this is the issue, you know, with this small group, even though they're powering it to their overall benzo requirement for 7 days. But when you have a group this small, you can see that range. Their time to qualification was anywhere from 1.2 to 62 hours in that low-dose dex group, so it's a pretty heterogeneous group. So they talked about their lorazepam equivalents here. So in this study, they were using lorazepam as first-line treatment, and once they got them stabilized, they would use clorazepate. So I'm not sure if you guys are as familiar with clorazepate. We don't really use it at our institution, but that's the breakdown there. And I don't know if you guys agree with all those equivalents. The phenobarb is probably questionable, but we can come back to that. So, yeah, they wanted to look at their primary outcome that they powered it for was their overall 7-day benzodiazepine requirement, and then they kind of looked at some of these other ones, lorazepam requirements over the first 24 hours, and then their secondary outcomes were, some of their length of stay, intubation rate, seizure, even though those patients were excluded, before they were actually initiated in the study, but they looked at that once they were enrolled. So what was the results? So for their primary outcomes, there was no significant difference between placebo, low dose or high dose dexmedetomidine. And if you go through all their other secondary outcomes, there weren't any significant differences either. They ultimately did a post hoc analysis to see if there's a difference in the lorazepam requirement within the first 12 hours pre and post initiating the dexmedetomidine.
The first 24 hours.
I think they did 12 and they did 24 now.
Okay.
Yeah. And that was statistically significant, but again, that was a post hoc analysis that they did in this very small trial. So some of the limitations, there's always a danger in doing a post hoc analysis on an outcome that you weren't powered for, especially in a group this small, and then again, looking at those baseline characteristics, it was a very heterogeneous group. Obviously, they didn't find significance for their primary outcomes. We could also debate if those primary outcomes are a goal that we would all agree on. I think for us, the idea of trying to spare benzos, obviously you don't want any of that benzo-related delirium on the back end, but in general, if it's not going to decrease your overall length of stay, I don't know if there's any other real benefit to try to limit their benzodiazepines. Again, there was a pretty significant portion of intubated patients here, so if you're trying to avoid intubation, I don't know how relevant this would be. And then there's also the appropriateness of CEWA versus a Riker scale in this population. So CEWA especially, validated mostly for outpatient treatment of alcohol, which are all similar to a lot of those other scales. If you have someone who's in delirium tremens, it's going to be very difficult to score them appropriately because they actually need to relate their symptoms to the nurse or whoever's actually doing their scoring. So I don't know how valid it is in terms of diagnosing these patients and kind of monitoring it, but that's what they had used.
I think before we stop this, I think it's worthwhile to talk about their primary outcome being reduced benzo requirements without any sort of benefit to the patients, because I still hear this study cited to me by colleagues in critical care who think that reducing benzos in ICU patients is a goal outcome when it probably is not in people who are being treated for alcohol withdrawal, and in my opinion could probably be a harmful outcome.
Okay, that's a very interesting paper. At your shop, you said that the ICU docs really like dexmedetomidine. I mean, do they try to insert that into the algorithm for the withdrawal cases?
Yeah, and I mean, I think reading this paper, to me, it seems like shows a very clear negative result for dexmedetomidine, but the fact that it did reduce benzo requirements over 24 hours, I still hear as a positive outcome from certain people who will then push for dex in alcohol withdrawal to try to reduce benzo requirements.
That is interesting.
I think that all just comes from the idea that benzos cause ICU delirium, and nothing else could.
Yeah, and I don't know if you guys are aware of the Sawdust trial. It was one of these newer ICU trials that they published only in abstract in 2017, which basically showed the same thing, that there's no difference when using dex. It wasn't benzo sparing either. Ultimately, they stopped enrolling that trial because it was just too slow of an enrollment, but they did publish that abstract, and for whatever reason, our ICU colleagues will respond to that paper. If you show them that, and they'll say, oh, okay, so I guess it doesn't work, but yeah.
Oh, that's interesting. So I see we have one hand up, Dr. Misick. Let's see if he's out there. Mark, you there? Okay. I guess we're not getting through. Actually, Mark did write in a comment. Maybe that's where we're going here. It says, abstract says it all, no benefit in larger number of complications in the DEX group, bradycardia 25% versus 0%. Pretty biased study, still no benefit despite the post-hoc cartwheels and other stats gymnastics. This is still an antidote in search of an indication in the setting of alcohol withdrawal syndromes. Might have benefited in other clinical situations, but not here. Okay, yeah, no, thanks. So I'm not sure, Mark's audio is not working, so I'll be happy to relay it by chat. Yeah, interesting point. I mean, I like that. Is it really an antidote in search of an indication? I wonder if folks are using dexmedetomidine for other toxic scenarios and they like it. Any experience out there?
In our experience, we've used it a lot for sympathomimetic toxicity, and it works great. I would almost call it an antidote, but I think that you're treating vital signs in alcohol withdrawal and not treating the underlying disease process.
Right. No, that makes a lot of sense. I'm wondering if we could just ask some of our colleagues what they think. Let's see. How about if I pick on our friends down in Virginia? Hey, VCU, are you guys there?
Yes, we are here.
Is that Dr. Cumpson?
Yeah, this is Kirk.
How are ya?
Good, how are you?
Good. Any perspective on DEX? Do you guys use it down there? Any thoughts?
Well, we were just chatting about it, that mostly just used outside of alcohol withdrawal in the ICU for agitation to sort of in that or the weaning phase where they're going to extubate the patient soon. That seems to be the major use here.
Got it. No, that's a great point. And it also, Dr. Misick adds by text saying that it's definitely worth studying in this situation of sympathomimetics. I think that is a good point.
We've seen a number of cases where some hospitals, not necessarily here at VCU, but in our coverage area for the Poison Center will just use it for agitation or delirium, even in a non-intubated patient, just because they could titrate it. It seems like pediatrics too, right? We have a pediatric representative here, so very common for them too.
Yeah, here too, the pediatric critical care folks like it. And I know we're getting ready for Lollapalooza. I'm sure we'll be seeing that coming out soon. But alcohol withdrawal, I'm not entirely sure. All right. We're not seeing other hands right now. Do we want to move ahead to the next article?
Sure. So this last article, looking at ketamine as an adjunct, it's more recent. It's a retrospective observational cohort with 63 patients, and they were all diagnosed with delirium tremens by DSM-5 criteria. They were all in the ICU, and they had received symptom-triggered treatment with benzos and barbs as first line, and they started on ketamine on an infusion, some with a bolus, some not. The doses between 0.3 to 0.15 mg per kg per hour. The baseline characteristics. So the baseline characteristics here are pretty similar between the two groups compared to the last one.
The other thing to point out, too, is that a lot of them are being admitted to the ICU with other primary diagnoses. So if you compare that to, like, the other DEX study where, they were excluded for any reason at all, that there are a lot of other primary diagnoses here, and then we're managing their withdrawal secondarily.
And then so here, because benzos and in some cases phenobarb were the primary intervention, the diazepam equivalents given here, diazepam was the preferred agent. So you can see it's a little different than the other equivalents and maybe is up for debate as well.
And then I just put that was the equivalents that were noted in the dexmedetomidine paper. It looks like both our group and that those authors pulled from the same article, from the Miller and Gold article from 2007. So I'm not sure what the discrepancy is in the phenobarbital. We just double-checked it again today, and it looks like our equivalents were correct from that paper. So I'm not too sure where theirs came from.
And so the outcomes looked at here were looking for reductions in ICU days, hospital days, intubations, benzodiazepine doses again, and propofol time. They looked at people who needed propofol or not, which was not significant. These were the significant reductions found with adjunctive ketamine use.
And then here are the outcomes. So you can see we have many significant outcomes. So just to highlight a few, so mean ICU days, 11.2 in the placebo group versus 5.7. So the mean reduction was close to 3 ICU days. Also mean hospital days as well, 16.6 versus 12.5, close to about 4-day difference between the two groups. The overall diazepam equivalents in both groups, difference of about 1,000 milligrams of diazepam, which should be significant. Maybe for some of you guys, that's like 5 healthy doses of Valium, but I think it's still pretty significant there. And then you can see, some of these patients did get either Precedex or propofol as an adjunct. At least in the propofol group, it did significantly decrease their overall propofol time. And then last but not least, probably one of the more important outcomes was the decrease in intubation rate, 22 intubations in the placebo group versus 10 in the ketamine group, and that was a p-value of less than 0.001. And then these are just further characteristics of that ketamine group. As Ryan alluded to, only a little more than half actually got the ketamine bolus. Their infusion rates, again, were anywhere between 0.15 and 0.3 mg per kg per hour. And then you can also see their overall diazepam equivalents that they had received during their therapy. And then obviously compare that back to the first paper with the lorazepam infusion. And these are considerably lower doses and overall mean shorter treatment times too.
And just to point out, the bolus dose was usually 0.3 milligrams per kilogram or less, so it wasn't like a huge bolus. It was less than the dissociative dose. And so discussion of this paper, obviously the reason that this should work, and it seems like it does work, is because it antagonizes the NMDA receptors. So when you already have your GABA-A agonism, using an adjunct with similar mechanism to alcohol should be useful. It reduces your need for intubation when you're reducing things like barbiturates, even benzos, and then the ketamine itself doesn't have significant respiratory depression, especially at these lower rates. And then the favorable kinetics of ketamine is pretty fast on, fast off. So if you can reduce your benzodiazepine dose or even barbiturate dose by thousands of milligrams or even hundreds of milligrams, you can imagine that would significantly reduce people's hospital length of stays.
And then this is just, we can talk about our current practice too, what we do. So in general, if we are starting someone on ketamine now, all these patients are getting bolus. We actually had a tox floor, a tox pod, where we keep a lot of these patients. So a majority of them were keeping out of the ICU by using ketamine. So not only are we avoiding intubation, we're avoiding ICU stay altogether. And then usually they'll be on the ketamine drip for anywhere from like 2-3 days, maybe 4 days maximally. But with that in combination with benzos, they're usually fine by the time that we turn it off. And, you know, we're still using other adjuncts like phenobarb. But typically, in our experience, people don't really end up in the ICU unless, one, you know, we've actually given them some healthy doses of phenobarb because they were so refractory, or if they have other comorbidities, other diagnoses that might require ICU monitoring or treatment. So that was the last David S. Pumpkin.
Love that slide, awesome. That was really interesting work, and I mean, it is interesting. You've got all the positive p-values in this study. That's interesting notes from your group. You know, a couple of questions. Like, you're in a very specialized environment, having a tox floor. You know, do you think can you transfer this experience? Do you think to another hospital that doesn't have a group of toxicologists at the bedside?
I think you're right, Steve. It is sometimes challenging in other hospitals that we go to that we're really lucky having this tox floor because the nurses get comfortable with our crazy doses of meds. I tease people, we treat toxicity with toxic doses, and they know, you know, sort of our pattern. So that's why we've been allowed to use, through our P&T committee, to use ketamine at these doses on our tox floor, but really the only other place that this can be done is the ICU. You know, because ketamine is labeled as a general anesthetic, and so the hospital powers that be are usually nervous about allowing use of this medication on general hospital floors, and that's fine. It's just, in our experience, though, I mean, we can even save more hospital costs by using a specialized unit, specially trained nurses who are comfortable using this, and use ketamine, you know, adjunctively with Valium or phenobarb or what have you, to keep them out of the ICU. And they do really well. They don't aspirate. They, you know, keep the head of the bed up, and so on and so forth. So you're right. It may not be generalizable to every hospital.
I think one way it could be applied more broadly is if someone is in an emergency department with severe delirium tremens or some sort of refractory alcohol withdrawal, ketamine could be initiated earlier on, and then if the patient is going to the ICU anyway, starting a ketamine infusion in the emergency department wouldn't be unreasonable because it seems like ketamine is used more often in emergency departments than anywhere else.
Yeah, that makes a lot of sense. I see our friends down at UT Southwest. I'm sorry, can you guys hear us?
Yes, this is Paul Wax, and I'm in Dallas. I'd like to welcome all the new first-year fellows from around the country to our Journal Club as well. I realize this is the second week of fellowship, and you're all in for, I think, a great ride over the next couple of years. And ACMT is offering a lot of variety of activities for the fellows, including the upcoming board review course, which some fellows, including our fellows in Dallas, will be attending. And the early bird deadline for that is July 25th. So that's just a little advertisement for something upcoming. Tony, thanks so much for leading this and your paper, which is really a great paper, bringing up new ideas in terms of the treatment of ethanol withdrawal. My approach over the years has always been to try to put these patients to sleep. And I'd like propofol, not knowing much about ketamine until today, because it is effective in putting patients to sleep when they otherwise will not sleep with their lorazepam, and also mechanistically, addressing the glutamate receptor issues, I think is critically important, and that's one of the major limitations of benzodiazepines, that it, as was mentioned, doesn't address the receptor. So my question is, in terms of the use of ketamine in the emergency department, as you alluded to, there's often limitations in terms of the indications for ketamine use, and some emergency departments, may not be able to give it as a continuous infusion. So I'm just wondering whether in Pittsburgh or anyone else from around the country has experience using ketamine in the ED for the initiation of these patients, particularly to try to prevent them from going to the ICU, as you suggested would be one of its uses. Thank you.
Obviously, Paul, I mean, we at Pittsburgh do. We'll use it fairly regularly. But I think the vast majority of our cases, the severe withdrawal, like a lot of our patients don't get admitted for withdrawal. They get admitted for something else and then go into withdrawal. So yeah, I think the vast majority of these cases end up on the floor before we start even considering ketamine. But yeah, but we certainly have used this as a means to bridge them and keep them out of the ICU. But you're right, I'm not sure other people have that capability.
Yeah, and so one further question. So on the floor, I realize you have your special tox unit in Pittsburgh, which is to be quite admired. But in terms of the floor, do others have experiences where they're consulting on a patient that's on the floor and the patient's gone into DTs and has become quite agitated and is not responding to the benzos, where they'll start the ketamine on the floor, again, to avoid ICU admission?
That's a great question. And again, if anyone hasn't, would like to weigh in, please raise your hand. And, I just out of curiosity, and especially with the benzo shortage, I know we could probably have a whole conversation just on the use of phenobarbital. But, Tony, where do you guys insert phenobarbital in your algorithm for treating these folks?
I mean, historically, Valium, for whatever reason, has been sort of our first go-to drug. But you're right, with the Valium shortage specifically, we do like phenobarb, and we'll use it regularly. Matter of fact, a lot of our intensivists often use IM phenobarb, interestingly, with some of their withdrawal, sort of as a prevention of withdrawal and those with risk factors. But yeah, I think Valium and phenobarb we typically use for our sicker withdrawals, and then we'll use Ativan for our maybe less sick withdrawals, sort of our unwritten rule here.
Got it, got it. Yeah, we've been using a lot more phenobarbital with the shortage, and it's been fun watching our residents get a lot more comfortable with that. But where to insert ketamine, I think it's really multidisciplinary, because especially for the folks in the ED, you're handing these off to the unit, and if you're following through as the tox service, you can really merge those two goals. I was wondering, maybe we can reach out to our folks in Portland. I don't know, Zane, if you're on the line, or Rob. Any other thoughts, your approach to alcohol withdrawal?
Well, honestly, we don't get consulted on a lot of these from the MICU. This is kind of a bread and butter thing. As far as Paul's issue, none of these drugs, including more than 4 milligrams of Ativan, is permissible on the floor. So all these patients go to the ICU. Ativan drips, phenobarb, was usually our next go-to for alcohol withdrawal, at least in the ER. And then the ICU, if they're intubated, are usually using either dexmedetomidine or propofol or fentanyl and Haldol often in the mix as well. So like Paul said, anything that can get you to sleep seems to be an option, and it's very fielder's choice preferred.
That's super interesting. It really speaks to the variance and setting. I know here at Cook County, 100 milligram of diazepam will get you an ICU bed, but we pretty much have to hit that. It's interesting, 4 milligrams. And I think it's really different. Like, we also don't get consulted on alcohol withdrawal besides the initial approach in the ED from our ED colleagues. Great.
Well, we're really proud in Pittsburgh. We're a alcohol withdrawal center of excellence. Everybody's drunk at some point, and so everybody goes in withdrawal. So there's plenty of withdrawal patients around. I think maybe in Portland they're just, more well-conditioned. I don't know. They're just, more relaxed or something out there.
Yeah, well, we got all the edible marijuana you want, so why don't?
Steve, can I ask Tony a question?
Yeah. Sean Bryant's here with a question.
Hey, Tony. Sean Bryant. Hey, I like the study a lot. Thanks for presenting it. I also like ketamine. I have no experience with infusions, but my question is, with your experience, if you could do this again, would you choose, or if you could, would you choose a higher dose? do you think that might be more beneficial?
That's a very good question. It's interesting how this all came to be. You know, we see so many withdrawal patients. We've noticed there was a subset of patients that didn't respond to benzos, and we're like, what receptor are we missing? Oh, we're missing NMDA. And then the light bulb went on when the pain service started using ketamine in a continuous infusion for chronic pain. And I'm like, oh, this is a perfect opportunity to jump into that. But then we realized we started with the pain doses that are way too low. So we cranked up our dose a bit where we landed. But I agree. I mean, I think there's so many ways we can study this. I think you can easily ramp up these doses theoretically to see if even higher doses are better. Because there's certainly a lot of cases where we see they're really sick withdrawal that, they, you know, even here we move them to the ICU where, like, they're on our high-dose ketamine, we're pushing phenobarb and Valium and what have you, and sometimes you just have to intubate them and put them on propofol, or, you know, so you wonder, like, can you just crank up the ketamine? That's a really good question, and this has just been completely sort of empiric dosing, and I think there's certainly lots of room to potentially increase the dose.
Great. Great. All right, awesome. Okay, I'm not seeing other hands. Did you guys have any other wrap-up comments?
No, we just like the opportunity to talk about this. This is fun, and always appreciate feedback too. I mean, like I said, we do a lot of withdrawal, and we're always trying to looking at ways to make it better. So if anybody has any feedback, please shoot us an email, whatever, and we're always looking to collaborate too. So.
Yeah, absolutely. Yeah, thank you so much, Tony, and Ryan. This was really, it was a fabulous discussion. No, I think your consult service is really a model to the rest of us in terms of, you know, how you really are in all parts of the hospital and you own a lot of these cases. Fabulous. Just as an announcement, the next National Journal Club will be September 11th, and the Einstein group with Serge Simpson will be running that. For any programs that would like to schedule a slot, give me a call, but I'll be reaching out to some folks as well. But with that, again, Pittsburgh Group, thank you so much, and we will see you next time.
Thank you, Steve.
Thanks a lot.